Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for the Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is the pipeline, what's new in epilepsy research and therapy development. And we're pleased to have as our speaker Dr. Erin Okazaki, an epileptologist with Spectrum Health Comprehensive Epilepsy Center. So Dr. Okazaki, could you briefly introduce yourself, talk about your clinical and research interests, and describe your experience with this topic?
Sure. So first off, thank you very much for inviting me. I'm really honored to just be able to join in on this discussion. By way of training, so I came from Arizona and I completed all my training from neurology to epilepsy and clinical neurophysiology at Mayo. And like I mentioned, I recently moved to Michigan to join the epilepsy group here at Spectrum. So in terms of clinical interests, autoimmune epilepsy, I'm an adult epileptologist, and so I've been fairly interested in paraneoplastic and autoimmune causes of epilepsy. And in terms of keeping up to date on devices and innovations, I think it's a very fascinating field because it's continually changing. I think we are getting more and more information on even a daily basis, and being able to utilize and leverage technology with the research is very exciting. And we're seeing more and more of it integrated into clinical practice. And so it's a great time to be in neurology, especially in epilepsy. And so my interests have also, surrounded potential devices, particularly wearables, and even some diagnostic AI type algorithms.
Great. Well, we're definitely going to touch on all of those interests a little bit today. So while it may not seem like epilepsy is a big area of research, there really is a lot going on. This includes basic research on the nature of epilepsy on the cellular and molecular levels, animal studies, clinical trials, therapy development, diagnostic technology development, and then also, like as you mentioned, advances in seizure detection and prediction technologies. To give you a sense of the scope of epilepsy research, I did a quick search in PubMed, which is a database of biomedical literature, and I searched for the word epilepsy, and there have been nearly 8,000 publications on this topic in the last year alone. And similarly, I went on clinicaltrials.gov, and there are nearly 300 clinical trials involving epilepsy that are currently or about to start recruiting subjects. So because there is so much going on, the purpose of today's call is simply to provide a broad overview of what's currently in the pipeline in terms of epilepsy research and therapy development. And this should give us all some hope and excitement for what's coming over the next decade or so. It also might inspire some people to support research, either financially or by participating in a research study. So let's start by briefly talking about some of the areas of basic research into the cellular and molecular mechanisms of seizures and epilepsy. So what are some of the most common or promising areas of research within this field, and some of the questions we're trying to answer?
So I think when it comes to basic research or bench or laboratory research in epilepsy, the questions continue to be, they're quite diverse. And the nature of the question is also very specific. For instance, some labs spend like an entire lifetime just studying one particular protein or a cell, and seeing how that fits in the grand picture, the grand scheme of epilepsy, pathogenesis, and things like that. So essentially, there have been many areas where they've where research has gone forward on a very molecular level. But one of the areas that I thought was kind of interesting and has become quite a topic as of late is regarding traumatic brain injury and epilepsy. The area has grown in interest because we've gotten more information about traumatic brain injuries, and especially with a lot of the epidemiologic data, epilepsy has become a very recognized complication of traumatic brain injuries. I think there's a study done like in the early 2000s that actually said or reported that epilepsy as a consequence of traumatic brain injury accounted for close to 20% of all acquired epilepsies in the general population. And why it's such an interesting area on a very molecular level is that it presents a unique opportunity to study what the pathogenesis of epilepsy might be, because seizures are not always immediate. They don't always occur immediately after brain injury, and can sometimes be actually very prolonged in patients manifesting years later. So oftentimes it's difficult to differentiate the relevant pathologic processes involved in the development of post-traumatic epilepsy from more non-specific pathology that's related to the traumatic brain injury itself. And it's postulated that neuroinflammation plays a pretty big role. And so current research is looking really specifically at certain types of cells and what the cell's role is in inflammation. So specifically, the glial cells. So a paper that was actually recently published this last year looked specifically at microglia cells, which are these immune cells that live in the brain. And they've been observed to have two different types of responses. So the first type of response is they can get activated with kind of a pro-inflammatory response. So basically an injury happens or something happens, and the cells are able to release these cytokines that come in, if you can imagine, cleaning up debris and other pathologic stimuli. But this response can sometimes damage other areas of the brain that were not part of like the insulted area. The second type of response that can happen with these cells is more of an anti-inflammatory response. So the cell still goes in and it is able to clean up the debris and more of that toxic buildup, but it does so in a more controlled fashion, so it doesn't cause damage to the surrounding areas. And in that way, it almost promotes repair. And research, current research has been looking at what kind of influences these microglia cells to have either that first type of response or the second type of response. And the idea is that if you can identify what's influencing the second type of response, then potentially that could be manipulated in hopes of potentially preventing post-traumatic epilepsy or even in the future modifying the disease course. So just an example of how research looking into the pathogenesis of epilepsy is very concentrated and can be very, very focused on a particular cell, but it's actively some type of research that's being pursued.
Now is that pathogenesis similar to what you would see after a stroke, or is that a completely different process?
I think it can be extrapolated to any sort of brain injury. However, they're looking at this particular process as a model for insults to the brain. The mechanism of stroke is a little bit different. And I don't know that we're at the point where we can apply like an apples to oranges under the fruit umbrella type of scenario.
Right. And can you talk just a little bit broadly about the process of epileptogenesis and and basically how essentially brains can learn to have seizures, or go from an initial insult or signal of some sort or change that then even years later sometimes then starts the process of having spontaneous seizures. Can you just talk a little bit about some proposed mechanisms? I'm sure inflammation, as you mentioned, is one. Are there other ideas on that?
Sure. So certainly there's the idea of particular, I guess the way of thinking about epilepsy has changed, and the way that we think about seizures has changed probably in the last 2 decades. And this might be taking a little bit of a step back from a molecular pathogenesis, but basically we're looking at seizures now, and the more we study brain function and seizures, we see it's kind of manifested as a group of these very intertwined connections. So we've got a lot of different neurons working in a balance to regulate brain activity. And neurons, in their simplest form, they can come in, I guess, 2 flavors. And you can have excitatory neurons, and you can also have inhibitory neurons. And there are many, many different mechanisms that are playing into how these neurons work, and what causes them to fire when they do, or what causes them not to fire, or what causes them to fire at certain targets and not others. And that can lead us down a discussion of particular channels, particular proteins. But taking a step back, when we're looking at that balance between these excitatory neurons and the inhibitory neurons, we're noticing that seizures are more of a manifestation of a misbalance between the neurons, particularly when those excitatory neurons start to fire, and then they kind of, I guess, in a way, overwhelm their neighbors, and create a fairly, I guess, chaotic scenario where the electric activity in the brain kind of goes awry. And this kind of highlights how we think about seizures as networks, and not just kind of one aberrant area that gets out of the barn. So I guess, for example, if we could take something like focal epilepsy, so presumably seizures starting from one area of the brain, say perhaps maybe the temporal lobe. And people can have symptoms like deja vu, so you're associated with an area of the brain like the hippocampus, or you can have an aura where you start to smell something that doesn't smell right. And as the seizure is allowed to progress, and as it starts to involve other neurons, further regions become affected, and then they can manifest as what we start to see, typically loss of awareness or losing motor control. And however long it's allowed to progress, it can recruit more and more nerve cells around it. But interestingly, though, after that process, then the parts of the brain return to kind of this normal function. So, smell becomes normal. People regain motor control. People regain, their ability to taste and things like that. So in this way, you have healthy and functional networks that get recruited during seizure activity. But you also, in addition to that, have that aberrant something, that's not right, that's not functioning the way that we had hoped it to function, that's starting this aberrant activity. And on top of that, you have another layer where other areas are continually not as quote unquote good as they were before. Things like memory, cognition, and mood, they also become impacted. So this whole idea of seizures and pathogenesis is now being seen as more from a network perspective. And in that way, it helps us to better understand not only just the onset patterns and the small little molecular components that might go wrong in that sense, but it also helps us to get an idea of what propagation might be. And, as the seizure continues on, what other areas of the brain are being affected, that in turn helps us to kind of understand better what disease progression might look like. And in many cases, especially with epilepsy, comorbidities, such as, memory difficulties or cognition or mood issues. And I think that has played out a lot in, many, many areas of research, especially when we're talking about therapies and we're talking about new detection devices and things of that nature.
Right, right. Okay. So this basic research is so important because it feeds into applied research on new therapies, neurodiagnostic testing, and new ways to detect or predict seizures. So let's talk a little bit about the types of advances we're seeing in diagnosis and pre-surgical evaluation. What are some recent and emerging improvements in EEG, neuroimaging, and other diagnostic areas?
Sure. So I think one, when it comes to diagnosis, I think that we're starting to recognize that there are a lot of other new types of syndromes or symptoms that we're seeing that are accompanied by seizures. And one of the more recent emerging fields in epilepsy are seizures that are related to aberrant antibodies or an autoimmune cause. And this is actually relatively new. 16 years ago, this was just coming out as a possibility. So these are people that have seizures that have a very explosive onset. They, for all intents and purposes, have done very well their whole life, and all of a sudden they start to have really bad seizures that are not that are refractory to medication. They also might have some neuropsychiatric symptoms, and we're starting to understand and broaden our understanding of what might be causing these epilepsies, these paraneoplastic or autoimmune epilepsies. And as we start to understand more about it, it's helpful because now we're starting to recognize and diagnose, being able to diagnose patients with autoimmune or paraneoplastic epilepsy because the treatment is very, very different and it is very, very time sensitive. So, for instance, in patients that have paraneoplastic encephalitis or seizures related to inflammation, an inflammatory process in the brain that's mediated by antibodies, we're able to detect through either the spinal fluid or through blood work if they have specific antibodies that are typically associated with cancers. So, for instance, lung cancer has a very specific antibody, testicular cancer, small cell lung cancer, or thymomas. These are all cancers that potentially produce these antibodies that can attack anywhere along the neural axis or even in particular systems in the brain, causing very, very bad seizures. Research, interestingly enough, has shown that sometimes people present with the seizures and with the neuropsychiatric symptoms before the cancer is even discovered. And this is a little bit different from autoimmune epilepsy, which is caused mainly by antibodies that are not particularly cancer-related, but these antibodies attack the cell surface and the proteins. We have been able to identify so far specific antibodies associated with autoimmune encephalitis. I think one of the more famous ones is the anti-NMDA antibody. But so far as we have research in the last 15 years or so, the battery of antibodies has become longer. The interesting thing about diagnosis and treatment is that both of these types of epilepsies tend to do much better when they are diagnosed early. And oftentimes centers are, if you don't know about something, you're not going to test for it. And as we're understanding more about how to treat these patients, not just with anti-seizure medications, But with immunotherapy, such as like IVIG, or which is an intravenous immunoglobulin, or plasma exchange, or rituximab, medications that are typically not used for your garden variety epilepsies, that it becomes more important to identify and to start treatment. At this point in time, there's really no protocol either on how long or how often or even how to gauge clinical improvement with these types of epilepsy. So it's a very emerging and it's a new field. And I think that as we improve our diagnosis, capabilities, that will be able to improve outcomes, especially for people that have been identified in this particular epilepsy subset.
Right. Now, in terms of like EEG and neuroimaging advances, is the general trend just simply towards improved resolution and increased sensitivity and that sort of thing, or are there any other developments in terms of the new technologies, ways of looking at the brain or the brain's function?
I think in terms of neuroimaging, a lot of it is still being able to improve detection and resolution. The 7T MRI, of course, is I compare it to like the Ferrari versus the the 2005 model versus the 2019 model, but we're able to see things with much more clarity and with greater detail. In terms of EEG, stereo EEG certainly has become much more used in the United States, basically where electrodes are implanted within the brain parenchyma itself. But other ways in terms of improving EEG, improving artifact on EEG, have also been recently studied. There was a paper that was published not too long ago that was looking at different sorts of back source ways of back averaging, basically to filter out particular EEG artifacts, because when we're reading EEGs, oftentimes there is a lot of artifact either from movement, either from electricity, or any sort of external sources, and we'd like to be able to get the EEG as quote-unquote clean as possible so that we aren't reading artifact as being something that's pathologic.
Right, and that seems like that could have a big impact, particularly on general neurology, who may be more prone to overinterpret or mistake artifact or benign variants as epileptiform discharges. So that's good. That sounds like a really helpful technology. And then obviously a lot of improvements in genetic testing too, but I'll just simply refer people to our previous Learn and Share conference call that we had last month, because we talked a lot about that. So great. So one of the most important areas of epilepsy research focuses on seizure detection and prediction. By using a combination of EEG and other physiological data, we hope to be able to alert people when a seizure is occurring or is about to occur or even is likely to occur. And this technology could then be paired with therapeutic interventions to try and stop or prevent seizures. So most likely these functions will be provided through wearable or implanted devices. The RNS, or NeuroPace, or responsive neurostimulator, for example, can detect the onset of a seizure and then deliver stimulation to try and prevent, stop, or shorten it. But right now it doesn't have an alert feature and often does not detect seizures soon enough to prevent them. And on the other hand, devices like the Embrace Watch can alert people to a seizure, but they can only detect seizures involving rhythmic movement and can't prevent or stop seizures. So can you talk about what types of detection and prediction technologies you envision in the near future and some of the research that may be involved in the development of such devices?
Sure. I think the area of seizure detection and prediction is always going to be very current because in a way we're trying to have clairvoyance and predict the future. I think RNS, like you had mentioned before, in many ways it's kind of disrupted like our traditional notions of seizures and seizure therapy and how we can possibly deliver therapy into the brain. So the RNS device, of course, requires implantation into the brain where we think seizures are coming from, and it is like the culmination of many, many months of planning and intracranial monitoring, so monitoring from within the brain. And then its therapy is going to be triggered based off of the identification of a specific electrographic pattern. But it's not a perfect system. We only have 2 leads, and some seizures, of course, don't originate from one area. But I think that we are, from the RNS, able to collect intimate data regarding seizure patterns that previously were not accessible on scalp EEG. I think it's a young device, and so as we learn more about the device and its capabilities and as time passes, we'll be able to better contextualize seizures and make device improvements. What I'd like to see is perhaps a combination almost of an RNS type device and something similar to a wearable like the Embrace. So switching gears, the Embrace, of course, it's a completely different modality. It's a wearable device that you don't need to go through that very, very long, extensive surgical planning and invasive monitoring to be able to use. These devices are options to everybody. And basically, in a population where you're suspected to have a seizure or seizure-like events, you can use the Embrace device and potentially be able to help with that diagnostic, gain a little bit more clarity in a diagnostic sense. The movement-based sensors, so the Embrace device, of course, has a accelerometer and a gyroscope, and the movement-based sensors is for the detection of convulsive seizures or, just based on upper extremity movement. And it's actually a really up-and-coming area of research. There was a study that was published not too long ago, I think just a couple months ago, in epilepsy, where they looked at using the wearable movement detection systems to detect post-ictal immobility. So basically it was detecting how long somebody wasn't moving after a seizure. And the idea was that in identifying the presence and the duration of that period of immobility, that it might correlate to other risk factors such as SUDEP or sudden unexplained death in epilepsy, which would help patients, would help families. You can put an alert on the device and it can tell you, hey, this person hasn't been moving for us, someone needs to go check on them. And briefly, what they found was that, yes, they were able to correlate the duration of that post-ictal silence or that accelerometer silence where there wasn't any movement and correlate that with post-ictal immobility and duration of EEG suppression. So this has generated particular interest in the sense that you're using a wearable device to record post-ictal movement patterns and then kind of giving that context to those outward physical manifestations that we see in seizures and in the setting of SUDEP. When it comes to using these devices in tandem, I would like to, I don't know if this will ever happen, but ideally it would be neat to have kind of a merger of these technologies, a wearable technology and an internal device similar to the RNS that can deliver therapy. And it would be neat to basically use technology to detect off of maybe particular bioparameters that are very specific to an individual and their seizures. And then based on those bioparameters, maybe taken from a movement-based sensor or something, or a sweat sensor or something, to be able to then communicate with an intracranial device that would, like the RNS, potentially be able to deliver therapy, almost like a merger of those two devices. Now, I don't know if that's just a pipe dream. It's probably just a pipe dream for me, but I think that would be very beneficial, because not only do you have something that can detect something on the surface, something that's wearable, something that looks, for most intents purposes, it looks like a watch, or it's a smaller device. You can also couple that with very, very powerful recording and therapy delivery technology that you might see, that you can see in a device similar to the RNS.
Right. And I think a lot of it is, just the development of the algorithms that will take into account multiple physiological input and be able to say, okay, if it reaches this threshold of various physiological markers, then we think a seizure is going to happen, and we're going to deliver some sort of preventive therapy or something. I mean, you look at the VNS, and they've just somewhat recently added the heart rate feature. So it seems like, again, there's this movement towards being able to take in data from multiple sources, physiological data, and kind of meld that into some sort of prediction algorithm. So it's definitely very exciting, and it seems like we're just kind of in the infancy of that. So glad to hear there's a lot more going on in that area. So now let's get to the main portion of our discussion, new treatments. So let's start with medications. Unfortunately, while we've seen significant improvements in side effect profiles and drug-drug interactions over the last 20 to 30 years, we haven't really seen any major leaps in terms of efficacy. We have seen several drugs with new mechanisms of action, though, and that has given clinicians more options for treating different types of epilepsy. Can you provide kind of an overview of the anti-seizure medications that have been most recently approved and some of those in the pipeline that are particularly promising?
Sure. I think that the medication that's probably had the most press is cannabidiol, or brand named as Epidiolex. Basically, it is the first, and it's the only FDA approved cannabidiol medication that's currently on the market. Its mechanism of action is not very well understood. We suspect that it's probably acting on the cannabinoid receptors, but very detailed information, so to speak, is I think there's still a little bit of a gray area. However, they have done basically the FDA has indicated this for the treatment of patients with Lennox-Gastaut syndrome. Basically, this is a syndrome that appears in childhood where kids have multiple seizure types, cognitive impairment, and then a very specific pattern on their EEG. And it has been found to help with one particular type of seizures in Lennox-Gastaut syndrome, or the drop attacks, when patients just lose tone. And as you can imagine, would certainly lead to injury. The other indication has been for Dravet syndrome, where the sodium channel has a particular mutation in the gene, and causes these people have a tendency to have very prolonged convulsive seizures. And then, of course, other indications, tuberous sclerosis. And basically, the cannabidiol is taken, it's in liquid form, and it's metabolized in the liver. And so there are a couple things to be aware of. when you're using it with clobazam, or the brand name is Onfi, this can sometimes increase somnolence. And then Depakote is another one to be aware. Sometimes it can kind of alter your liver function test. But mainly it's a very well tolerated medication, with the most common side effects being some diarrhea, somnolence, and decreased appetite. That I would say Epidiolex or cannabidiol has been probably the most has been on the forefront in the last 8 to 12 months. Other medications that have been recently approved, stiripentol. Basically, it modulates a receptor called the GABA A receptor, and activates that. And it's been approved by the FDA for patients with Dravet syndrome that are taking clobazam or Onfi. And it did demonstrate in some small trials that there was improvement with these big generalized tonic-clonic seizures in patients that had Dravet. Interesting enough, stiripentol has been used in Europe and has been approved in Europe for a while. Typically, the most common side effects here are going to be decreased appetite, some somnolence, some agitation, and maybe some ataxia, so some coordination issues. The most recently approved medication, in June, I think the end of June of this year, was fenfluramine. And again, this is approved for Dravet syndrome. So the idea behind fenfluramine, which is in the past been marketed as Fen-Phen, or the diet pill back in like the 80s and mid-90s, is the idea is that in addition to promoting the release of serotonin, it also controls a particular receptor that's found on the surface of nerve cells, and that helps in regulation of different neurotransmitters. Basically, researchers found that when this drug was added to patients' existing therapies, that within a month, so about 3 to 4 weeks, patients also reported a decrease in convulsive seizures. So these 3 medications specifically, fenfluramine, stiripentol, and Epidiolex, it's been quite a banner year for Dravet patients with Dravet syndrome, which is a huge thing because seizures in Dravet syndrome are debilitating, and there has not been a lot of medications that have been known to be helpful. In the adult realm, the biggest drug has been Xcopri or cenobamate. And again, this is just an overview of the medications, but basically this acts on the sodium channels and it inhibits them. And it also can work on a particular receptor, again, the GABA A receptor. But it was approved last year for patients that had focal epilepsy, and basically the take-home message is that the studies are very, very promising, but there were some hypersensitivity reactions, so that means that people had some very multi-organ, basically the medication caused them to have in a way, a drug reaction, and so they ended up having very systemic symptoms requiring hospitalization. But the take-home message is that very similar to Lamictal, if you start at a low dose with cenobamate and go slowly, it's actually done very well for a lot of people. Part of the reason why we want people to go slow, start low and go slow on it, is also because you can have excessive drowsiness or fatigue, to the point where the manufacturer also recommends patients maybe not drive or operate machinery until they've kind of been able to gain some tolerance with the cenobamate. But overall, fairly well tolerated. most of the side effects typically are somnolence, and it's been dose dependent, some dizziness, headache, and fatigue. So I think that overall, when we're talking about new medications, it's interesting to note kind of what it means to be effective when it comes to medications, because we're hardwired in many ways to determine effectiveness by seizure reduction and being able to count, okay, you've had X amount of seizures, which is less than before, so is this working? This probably is working. But I do think that there are other factors to take into account, particularly side effect profile, cost, delivery mechanisms. And despite the fact that we don't have a medication that completely like eradicates seizures or gets rid of it, I do think that the more medications that have become available in the last 20, 30 years do offer a more options to people in terms of finding out what medication choice might work for them, because ultimately the goal is always using the most effective dose with the least amount of side effect.
Right. Definitely important. Are there any currently in development that kind of stand out as being particularly unique, or are many of them kind of just looking at sort of variations on a theme, like more sodium channel blockers or more or variations of existing medications? I guess what's your overall impression of some of the drugs currently under development?
Yeah, I do think that it's interesting. I think that we are still dealing with a lot of variations on a theme. The more bench research that comes out about even, particular cells, particular channels always generates a little bit of interest. But every time a drug comes to market, it's probably a testament to 60 or 70 or 80 other, hundreds of other drugs that didn't quite make the vetting process through. So in terms of like completely novel mechanisms of action for drugs, not particularly different neuromodulatory therapies or anything, I think what we have so far is, especially for Dravet syndrome, is manifest to being able to capitalize in a productive way on knowledge that we already have.
Mm-hmm. Right. And I'm curious because of the kind of growing knowledge of the role of glial cells, astrocytes and microglia, and are you aware of whether, or do you think that there's at least potential for there to be drugs that target those cells rather than the neurons specifically?
I think it's definitely I think it, 10, who knows what time from now, but I do think that it is a worthwhile target. Especially the more that we learn about glial cells in the setting of neurology in general. I know that there's been some studies looking at glial cells in ALS and looking for new drugs that might be able to basically modulate the expression of the different cells. I think that it is a very worthwhile area of therapy. And two, the more that we learn about how the microglial or the glial cells, astrocytes, oligodendrocytes, the more that we learn about how they function with each other, the more that we'll learn how to manipulate and then kind of harness the qualities that we want. It's kind of like reading EEGs. Like the more you see a normal EEG, the more meaningful the abnormal EEG becomes. And I think that's kind of the way when it comes to research around, especially glial cells, which I think will take off in neurology in general, especially in epilepsy.
Right. Okay. In addition to daily medications, there are also some new as-needed or rescue medications available. and in development. We had a call earlier on rescue medications, so won't need to go into much detail, but can you just briefly discuss some of these?
Sure. So Nasolam, or it's a midazolam nasal spray, is a rescue medication that belongs to the benzodiazepine family. Very unique delivery mechanism in that it's in the form of a nasal spray. This is similar to Valtoco or a diazepam derivative. So Valtoco is a diazepam benzodiazepine, and it's also delivered as a nasal spray. So Nasolam and Valtoco came on the scene this year. The difference is that Nasolam is approved for people that are 12 years and older versus Valtoco, which is 6 years and older, and the dosing varies. Nasolam, you can give a second dose after about 10 minutes, and then Valtoco, you can do it, I believe it's after 4 hours, the next administration. But these rescue medications have definitely given, especially for adults, a viable, discrete option that doesn't include like a rectal diazepam. The other medication that's kind of in development is this staccato alprazolam, and so alprazolam is otherwise known as Xanax. But basically, it is also the benzodiazepine class, and the person just puts their lip on the delivery mechanism, and they take a breath in, and then the drug is aerosolized, and they're able to get it into their lungs where it will diffuse into the circulation. So I think that the staccato alprazolam is a very neat and a unique method of drug delivery. It would require somebody to be able to inhale. Because sometimes, when people are in their seizures, ideally you'd give this before they go into like a full-blown convulsive seizure. But being able to have the option of inhaling versus having somebody to spray a nasal spray, I think these are delivery mechanisms that, for many, many years, the adult population didn't have at their disposal, because oral Ativan takes a certain amount of time and to get into your system, and most people don't walk around with an IV kit and can't really give themselves a certain IV if they run into trouble. So these, I think these are definitely game changers.
Great. So we talked a little bit already about neuromodulation, but this is definitely another very much growing therapeutic area. Can you talk about potential ways to build upon existing devices, and then discuss any other devices or neuromodulatory therapies that are in development?
Sure. So the first part of the question, just building on existing devices, RNS probably being one of the biggest neuromodulatory devices. Currently there are different areas of the brain that we target with the RNS leads, but in the future, and even looking at RNS today, targeting other regions of the brain, not just the frontal lobe, the temporal lobe, the occipital lobe, or the parietal lobe, but certain regions like the thalamus are becoming quite, I wouldn't say popular, but becoming very viable targets, especially for patients they go through their intracranial monitoring and we find, your seizures are coming from a more diffuse area than we realized. We can start talking about potentially modulating other areas of the brain like the thalamus. As you had mentioned before, VNS, of course, an improvement is that, it's got the heart rate detector, which is a very neat functionality with it, so that we can be able to, I think, in a way, the VNS is probably the first device where we have an organic way, or basically a way of capturing organic system changes and using that as a way to kind of alert or deliver therapies. So in terms of existing devices and being able to work on further modulatory options, I think that the possibilities are endless, especially with RNS. The device is fairly young, and I think we'll have many, many opportunities to figure out, number one, optimization of the data that we're getting and being able to use that to help patient seizures, moving electrodes, more electrodes are definitely on the horizon. When it comes to so switching gears a little bit to other sorts of devices and neuromodulatory therapies, just wanted to touch a little bit briefly on some of the devices that don't require surgery. So VNS, of course, requires surgery to get the device into the body and then wrap it around the vagus nerve. RNS requires extensive surgery through putting a device into the brain itself. But other neurostimulation modalities called TMS or transcranial magnetic stimulation can basically use the magnetic field to induce an electric field, as it were, and to change the way that the brains are firing. So as in investigative therapy, it basically capitalizes on the brain's ability to adapt to certain electrical stimulation over time. And it was approved TMS was approved for depression by the FDA. But I think that its application to modulating electrical activity that gives rise to seizures is going to be, or continues to be, a little bit of a up-and-coming area of research. So there have been some trials that look at applying repetitive transcranial magnetic stimulation. And some people have reported some reduction in their seizures. Some people haven't. But it is interesting that some people continue to use the device even though they haven't noticed any seizure reduction because they had noticed some improvements in their mood, which is telling based on the FDA recommendations and kind of also our earlier discussion about networks and how seizures affect different areas of the brain. There are some other kind of variations on a theme, so to speak. With TMS, there's something called navigated TMS, where neuromodulation is used to just identify areas of the brain that control different functions. Another one is called PP-TMS, or paired pulse TMS, and that's another version of TMS where we're able to kind of identify where in the brain excitatory and inhibitory cortical responses are located. These are more academic forms, typically more for research purposes. There is something called transcranial direct current stimulation, which is different than TMS. So TDCS is another brain stimulation technology, and it uses a weak direct current, hence the name direct current stimulation, to increase or decrease the excitability in different regions. And basically, that operates under the assumption that influencing current in different directions can alter, the neuronal firing rate. So basically, they've started to do a couple of studies in some patients with pharmacoresistant epilepsy who aren't really surgery candidates, have shown some promise. But again, TDCS is still in its infancy. The last kind of neuromodulatory device to think about is a trigeminal nerve stimulation. So basically, this is different from TMS and TDCS, and it's been approved in Europe. But basically, what they're capitalizing on is in animal models where they were able to see that bilateral stimulation of the trigeminal nerve was able to reduce seizures. So basically, one study, there's one particular study that looked not only at applying TNS externally to see if it reduced seizures, but they also used it to see kind of if there was any improvement in quality of life and mood and in sleep. And again, interestingly enough, in this study where they used the trigeminal neurostimulations, patients did report an improvement in their quality of life and mood. And even though it didn't significantly decrease seizure frequency, people can still continue to use the device. So, I think that, again, this is all in its kind of infancy, but being able to see how external neuromodulatory devices affect the brain and affect seizures, affect mood, is a really interesting concept. Certainly we'll need more studies, we'll need more double-blind, we'll need placebo-controlled trials, but it's very interesting kind of the preliminary results that we're seeing.
Right. And the trigeminal nerve stimulation is sort of like a headband device, right? That's worn during sleep.
Correct.
And then the other two that you talked about, the transcranial magnetics and direct current stimulation, those are more hospital-based applications. Correct. Where you have to go into the hospital for a certain amount of time and get, So, interesting.
They're more involved.
Right. Okay. So laser ablation is the most recent advance in epilepsy surgery. Are there any other new surgical techniques on the horizon?
There are a couple. There's something called a focused ultrasound, and this is basically, it's non-invasive, so it doesn't require any cuts or anything to the brain. But basically, ultrasound wave technology is targeted towards different regions of the brain. And the idea is that where the ultrasound beams converge, it can produce some therapeutic effect on the tissue. And that effect can either be a ablation where it kind of heats and destroys the targeted tissue, or the other use would be for neuromodulation, where the ultrasound is used to basically give impulses and impact kind of this seizure patterns that they might be identified. There are several trials that are going on looking at ablating different regions of seizure onsets versus trying to lesion a specific location in the brain via this technology. And then equally, and if there's other studies that are just looking at ultrasound to try to modulate seizures by giving kind of these lower powered pulses to different foci. So the realm of ultrasound, especially in epilepsy, I think is up and coming. The other area that is showing some promise is regarding stereo EEG guided regular radiofrequency thermal coagulation. And basically it's where stereo EEG is combined with basically thermal coagulation. And the idea is that you are able to lesion or destroy an area of tissue that's thought to be the seizure focus. So instead of opening up the brain and, with a craniotomy, you can use stereo EEG guided thermal coagulation to produce lesions without having to make these huge craniotomies. Ideally, this is great for those lesions that are deep, deep in the brain. So something that's not on the surface, something that's very close to, if you can imagine, like the ventricles being in the center of the brain. So it's very, it can reach areas that are not typically highly accessible to your traditional craniotomy and lesionectomies. This technique is actually was recently used in the Lion Group in France. And they did report that about half of the people that underwent this particular procedure responded, with a reduction in seizures, and that under a quarter of the patients are actually seizure free. This is, of course, pooled rates. But they did find that the complication risk was fairly low, and they reported about 2.5% of patients had some sort of permanent neurologic deficit. But still, again, this is in the early stages, and it still needs to be vetted against our more standard practices. For instance, like an anterior temporal lobectomy. So very interesting
Right.
ways of trying to eradicate seizures in a way.
Right. Right. And the focused ultrasound is that completely non-invasive, or there's no incisions made, or what do you know about that?
Yeah, did no incisions.
Okay.
Basically, it almost looks like you go into, for lack of a better, like almost like an MRI-like machine. And then there's all these different cooling systems and things that are going around the head, but it's nothing like an invasive craniotomy.
Right. Right. All right. So while there's still a fair amount of research going into the possible mechanisms of action for the ketogenic diet and its potential value for conditions other than epilepsy, I haven't seen much in terms of developing new treatments based on the ketogenic diet. At least since the modified Atkins diet and low glycemic index treatment and other variants have been introduced. Are you aware of any such developments in terms of new variations on the ketogenic diet or new treatments based on the ketogenic diet?
As far as new treatments based on the ketogenic diet, not any that we're currently in practice with. I think there's some research that's gone into exactly what exactly makes the ketogenic diet so effective. But as far as being able to modulate or harness that and changing it into new treatments or basing treatments off of it, I'm not aware of anything that's very that we're using in clinical practice. I think it's hard because with the ketogenic diet, you've got all these different molecular and metabolic substrates and these enzymes, and there's so many different factors that are influenced by the diet itself. So it goes far beyond just that energy substrate ketone body role.
Yeah, and unfortunately, there's a lot of pseudoscience out there that talks about like ketogenic diet in a pill. Now you can have all the benefits.
Yeah.
So there's some kind of dangerous information out there that, but yeah, so that's kind of what I suspected, that there's not really much in the way, but we're certainly learning a lot more about why and how it works, and then also about other conditions like migraine or cancer or other things where it may have potential value. So. Okay, so perhaps one of the most exciting prospects in epilepsy research would be the development of a completely new type of epilepsy treatment, something other than daily medication, surgery, neurostimulation, or diet. Can you talk about some of the more promising areas of research that might lead to such a treatment?
I think that, interesting enough, coming off of the ketogenic diet question, there is some research that's going on about like gut microbiome and how it can be altered, and it kind of goes along the lines of the ketogenic diet in the sense that it's not a treatment, certainly, but they're looking at how gut biome can influence basically epilepsy and seizures. So in some studies, they were looking at rat and mice models, and the ketogenic diet showed an increase in particular bacteria species in the gut, and that downstream led to a reduction of particular amino acids and proteins and elevated GABA and glutamate levels. But basically, it showed that the changes in the gut microbiome were necessary, but also sufficient enough for seizure protection. Again, these are just experimental models, but they did say that gut microbes were able to modulate seizure susceptibility. That doesn't necessarily involve beta hydroxybutyrate levels, which is basically what ketones are measured. basically a measure of ketosis in the ketogenic diet. And so the mice in this particular study were treated with some antibiotics and ended up being germ-free, so to speak, but then lost the seizure protective effects that had come via the ketogenic diet. So essentially the ketogenic diet induced some sort of change and increased a particular bacteria species in the gut that resulted in seizure freedom independent of ketone body generation, which is kind of an interesting idea. But all that being said, though, there are some like popular science reports where people said, oh, they did do a study where people started taking probiotics and then they reported a reduction in their seizure after about 4 months. I'm not quite sure that that's been vetted in science yet. That study certainly wasn't placebo controlled, but it's something to think about, especially on the horizon if we're talking about completely novel areas of epilepsy treatment. Delivery, in terms of delivery mechanisms for medication, there was a study that was done regarding actually delivering medication to the brain via a pump. Basically, it's playing off the idea that we've delivered medications to the brain directly in cases of like meningitis or cancer of the lining of the brain. But studying that same mechanism of delivery for seizures in people that have seizures. And there was a clinical feasibility study where they looked at like basically drug delivery, specifically Depakote, that was delivered through an implanted infusion system. So these people that were recruited for the study were adults that had seizures, had previously not responded to oral Depakote, but were implanted with this system where the Depakote was delivered directly through an intra-abdominal pump hooked up to a catheter that was introduced to the brain, and they reported reduction in seizures. Their CSF level, so the medication of the level of medication that was in their cerebral spinal fluid was recorded, and they also correlated that with serum levels of the medication. And what they found was that the patients tolerated the therapy, and they were able to have high levels of the medication in their spinal fluid, with correspondingly low levels of medication in their blood, and ended up having very minimal drug side effects. They also were able to do some MRI images to make sure that the delivery of the medication directly to the brain wasn't hurting the brain parenchyma or causing any sort of brain changes as well. So very novel way of looking at drug delivery, still again in its infancy.
Right, and I've even heard of focal cooling as a area of investigation, of just simply having some device that can cool an area of the brain and has possible potential for seizure control. So a lot of interesting things out there that are very much in their infancy. So an important research goal in epilepsy is to develop a true anti-epileptic treatment. I know, the old term for anti-seizure drugs is anti-epileptic drugs, or AEDs, but we've kind of moved away from using that because it's not really treating the underlying process. It's treating just the seizures. So, how likely do you think it is that we'll have some sort of true anti-epileptic treatment that prevents, halts, or slows the process of epileptogenesis? And what are some of the possible approaches to that are being studied?
So I think it'll be a matter of time. Currently, resective surgery in some cases can cure epilepsy and render people seizure free. But I think being able to extend those same results via other modalities, kind of like in a lot of ways, there's some of the things that we talked about today will come eventually. I think, certainly being able to put electrodes into someone's brain and lesions based off of where the location of those stereo electrodes are is a very interesting modality, especially because we are in a way doing the same thing a resective surgery might do, but without the large craniotomy or without having subjected the patient to particularly more complications than necessary. But in the end, I think it's going to be that collaborative nature of medicine that's going to push things forward. It's the more people talk, the more researchers talk, patients talk, advocates talk, clinicians talk, and we're able to collaborate and use that information and couple that with technology is going to be very powerful, and I think will drive a lot of the innovation in the next 10 years or so.
Right. And I imagine much of the research into anti-epileptic treatments, that could be administered after a traumatic brain injury or after a stroke, for example, would be kind of tied to that basic research we talked about earlier, and maybe targeting inflammation or trying to coerce those microglia into behaving a certain way. Seems like there's ample targets for that type of research, and it's just a matter of how long it'll take to get there. And we kind of alluded to this earlier, but epilepsy often involves more than just seizures. Depression, anxiety, cognitive problems are all commonly associated with epilepsy, and in many cases can affect quality of life as much as seizures. Can you talk about the value of research into the shared mechanisms behind epilepsy, depression, anxiety, and cognitive dysfunction, and why it's important to include mental health and cognitive outcomes in clinical trials of epilepsy treatments?
Yeah. So again, kind of going back to that idea that epilepsy and networks in epilepsy, being able to look at seizures as not just an independent electrical event with physical manifestations, but really being able to see epilepsy as this complicated, intertwined network of multiple brain areas coming together to create what a seizure is, what the comorbidities are, and disease progression, I think, really underline the importance of including the concept, including measures of depression, anxiety, and cognitive dysfunction when it comes to epilepsy trials, clinical trials for epilepsy. I think we've seen this already to some degree in a lot of areas of epilepsy research. When specifically kind of looking at laser ablation, it's, being less invasive. Research saw that cognitive outcomes were a bit better. RNS studies certainly. We're looking at the neuropsychological involvement, particularly word finding improvements, memory, learning ability, thinking. People that have RNS have done better on these particular outcomes. TMS and as well as TNS, trigeminal neurostimulation, have also shown improvements with mood and depression. And I think that we cannot ignore this. I think that it's important that research is focused on this area, because if we ignore it, I think we're doing a very big disservice, because seizures are not just, like I said earlier, these electrical events. They impact people's lives in many other ways than just having the seizure itself, which is terrifying, which is disruptive, and which prevents people from having the quality of life they want. Some people, all they want to do is be able to leave their house, go to a restaurant and eat lunch. And, the anxiety if, well, am I going to have a seizure or what's going on? It's just so overwhelming that they can't even do that. And these are things that a lot of people, I think, take for granted. And so by including these areas in research, we can, number one, understand a bit better how these networks are working, but also better treatment parameters, better medications, being able to see if other medications that we use in epilepsy can be crossed over for other neuropsychological or neurocognitive issues, which we see already with things like Lamictal or Topamax for headaches and things like that. So, yes, very crucial,
Right.
very, very crucial and very salient.
Okay, great. So, given the time, I think we're going to go right ahead and open it up for questions. Okay, who would like to get us started with a question?
Yeah, my name is Matt. How long does the new VNS last?
Hi, Matt. The new VNS, so the VNS will depend, it's different for everybody.
I understand.
The battery life depends on how frequently the therapy is being given. So, and it depends too on
Roughly.
how much you're swiping, how much you're swiping the magnet. So, I mean, if you're looking for a range, 3 to 8 years, sometimes longer for some people, sometimes shorter, just depending on how long they're using it.
Okay. I just had one put in me like 3 weeks ago. I was just curious because my one I think, lasted about 8 years. And this one, I was just curious how long this one would last, or roughly.
Yeah, is there a difference between the battery life? I think there might be a slight difference in the battery life between the Aspire, which is the kind of the second most recent one, and the Sentiva, which is the most recent one, because the Sentiva is a little bit smaller, and I think it has a little less battery life. But is that correct?
I think I would have to double check.
Yeah, we'd have to check the
And look
manufacturer.
specifically to see, how long. Typically, the range that we give is 3 to 8, but again, it
Okay.
depends.
Okay.
It depends
Thank you.
on how it's used.
Okay.
Thank you.
Other questions?
Hey, Russ. My name is David. I have a question for Dr. Okazaki. You were at Mayo Clinic, so that's obviously not here. You're in Michigan now. Do you see consistency in treatment of epilepsy with these different devices and the different medications, even in other parts of the country? I'm just curious if there are perceived differences, or is it institution-based, or how do you make your decisions on based on your experience?
I think when it comes down to when we're talking about devices or we're talking about research, every center is going to be a little bit different about, the percentage of people that end up with a VNS or the percentage of people that end up with an RNS or resection. But I do think that the important thing is that it's still offered at every center that I've been at anyways. In terms of surgical options, in terms of medication options, any comprehensive epilepsy center is going to make sure to present all those options, and I see that that's been, that's a straightforward offering across the United States. I think that there's definitely probably regional differences too in populations, and in terms also of accessibility to maintaining the devices. It's different if you have somebody that lives in the middle of nowhere. Can they sustainably use RNS if they're 200 miles away from their neurologist or whatnot, or any sort of healthcare provider. so we have to take things like that into account. But across the board, I've seen that the same offerings are available, at any epilepsy surgery center.
That's great. Thank you. I was just curious.
Right. Yeah, and I certainly think that Michigan is very well positioned when we compare to other states in terms of the number of level 4 comprehensive epilepsy centers that we have. And I often hear people saying, well, should I go to Cleveland Clinic or Mayo Clinic or some of these maybe better known nationally, centers that are better known nationally maybe. And I think for the most part, you're able to get top quality care right here in Michigan, which is great. So, but again, there may be certain centers in certain areas of the country that specialize in certain things, but we're again very well positioned here in Michigan. So,
I think if you want to do like
go ahead.
I think if you want to be involved in like a cutting edge trial, then you'd probably, and I'm talking about cutting edge, like just out of the box, we're going to really try something different. Then you need to start looking at larger centers. But in terms of, larger centers that have the funds, that have the means, that have the support and everything to do these huge, very investigational, very, very, very brand new type of research. But in terms of getting good quality epilepsy care, I'm a firm believer that any level 4 epilepsy center will be able to provide that.
Okay. Other questions or comments?
Hey, Dr. Okazaki. My name is Lucas Sun. Thank you for sharing your presentation today. I just had a quick question about cannabinoids in the use of treating epilepsy. I understand that there is research out there that they've had used cannabinoids in the treatment of dyskinesia and Parkinson's, and I was wondering how levodopa and dopamine in general play in epilepsy. If the mechanism of action is unknown, how does dopamine play a role in epilepsy and seizure episodes?
So when we talk about basically when we're talking about dopamine, the area of neurology where it's most prevalent is going to be in movement disorders, because you're looking at things that can affect the enhancement or the decrease in movement. When it comes to dopamine and epilepsy, a lot of our drugs aren't really targeted towards dopamine. Basically, there is some evidence that dopamine can modulate these cerebral networks, the brain networks, either with some sort of anticonvulsant or maybe proconvulsant effect, but we don't really have great evidence to show that this would be something that we would target for treatment. It might play a role in basically some structures of the way kind of the brain is going to modulate movement in kind of like the basal ganglia area and stuff like that, and then how those projections from the basal ganglia go out to like the thalamus, and so there might be some areas of research there, but I'm not aware of any sort of drugs that are looking specifically at dopamine in relation to like the pathophysiology of epilepsy and how cannabinoids specifically and the cannabinoid receptor plays into that.
Awesome. Thank you. I appreciate it.
All right. So we are about out of time. So I want to thank everyone for joining us today, and thank you, Dr. Okazaki, for a really thorough and broad exploration of kind of the pipeline and what's on the horizon for epilepsy treatment. So So again, if people have any further questions about this topic or about any of the treatments or research discussed today, please feel free to call us at 1-800-377-6226 or visit our website at epilepsymichigan.org. Thanks again, Dr. Okazaki, and thanks everyone for joining us today.
Thank you.
Thank you for having me. Thanks.
Thank you.